Back 2-3. Welcome back to MedSchool Radio, and this is the fifth in the series of the autoimmunity videos. So, in the last video we were talking about Sjogren syndrome. So let's discuss the pathogenesis briefly. And what is this? That is unique about the pathogenesis of Sjogren syndrome in the type of immune reactions involved? Well, the important thing to remember here is that it involves both type 2 and the cell-mediated type 4 immune reactions. So type 2 are the antibody-mediated and type 4 are the cell-mediated immune reactions. And remember that 90% of the patients are women between the ages of 50 and 60 years old. So let's talk a little bit more about Sjogren syndrome. Can you describe any of the clinical features of Sjogren syndrome? Let's think about it. You would of course have dry eyes and dry mouth with variable salivary gland enlargement, secondary to lymphocytic infiltration. And how about secondary changes? You might have corneal inflammation, erosion, ulceration, atrophy of the oral mucosa, dysphagia, nasal drying, and laryngitis, for example. And in 25% of patients, you may see other organ involvement, for example, the skin and the lungs, kidney, muscles, and CNS. But one thing to remember, it's very important that there is no glomerular involvement. This is not a feature. If you're thinking about glomerulonephritis, then you would be thinking about lupus. Okay, so let's carry on with another question here. I'm going to describe the condition and you're going to name it. So this is characterized by small blood vessel destruction and excessive fibrosis of the skin and multiple internal organs. The etiology is unknown, and there are two forms. It is clinically heterogeneous. So the first type, diffuse with skin and early visceral involvement. The second type is localized with limited skin involvement. So this, of course, is scleroderma or systemic sclerosis. So let's discuss the mechanism here. Although the trigger is basically unknown, the trigger is released, and it involves an immune response which leads to the activation of T cells. And we have cytokine release, and of course we have endothelial cell injury. There is the recruitment of mast cells and macrophages, and then the release of fibroblast growth and chemotactic factors, interleukin-1, PDGF, and FGF. So then we'd have fibroblast activation, and on the other side we'd have platelet activation and aggregation, narrowing and thickening of small blood vessels, and ischemic tissue injury, all leading to fibrosis. So of course what we have happening here is we have fibroblast growth factors, and this is seen commonly, more commonly in females. And so although scleroderma or systemic sclerosis shares some of the same features as SLE or rheumatoid arthritis and polymyositis, the salient feature, the most important feature to remember here, is that there is fibrosis in multiple organs, and that it is primarily a disease affecting women, 3 to 1. So in advanced systemic sclerosis, you would see blood supply loss, claw-like hands, fibrotic features, and there is kidney involvement, death from kidney involvement in 2/3 of patients. There is progressive periarterial fibrosis, which may be clinically silent, and this may lead to death by renal failure in 50% of patients. But remember that the most common cause of death in scleroderma is not renal failure, it is hypertension. So why do we say this? Why this is important is because with hypertension you have kidney and lung death. Okay, it seems to have frozen there. Are we frozen? It looks like we may have